So thank you very much, everybody, for coming. The purpose really for today, it's a pilot study that we want to run in terms of the wellness program. We're very fortunate to have Catherine here, who's going to chat to us just now. But I just wanted to highlight, and some of this might be new to people, or it may, in fact, just be repetition. But in terms of the board's vision and mission, which was published in June last year, the board signed off on their new vision and mission. In terms of the vision, the statement is to guarantee the sustainability of Simbithi ecostate. And sustainability, to me, comes in various forms. One of which is obviously, as a community and a family that we think Simbithi is, we want to ensure that the health of our community is sustainable. And the screening through the ages fits beautifully into that vision, because it speaks not only to people that are sort of in the later years of their lives, but it speaks to every single sort of age category, which is fantastic. And then, as we look after the younger people, those people look after the older people, and we thereby sort of underpin the vision, which is the sustainability. So, when we go through these wellness initiatives, this is obviously the first of it. We do it with an eye on sustainability. We do it in an eye on the vision that is Simbithi. In terms of the mission, we want to be widely regarded as the preeminent eco-state in South Africa. I think that we've gone a long way to that point anyway. I would challenge anybody to point out more than 2 estates or eco-states in South Africa that are sort of at our level. So the purpose, and when you came in today, you would have signed a register. We want to create a WhatsApp group, obviously of like-minded people, to create a network. The idea to share thoughts, ideas on various initiatives which we can undertake to support wellness. Dependent on support, dependent on the engagement from our community, that will direct the board and assist management with decision making as to how we support this in future. Obviously, at this stage, we want to host at least once a month a wellness talk, and Catherine, who's been part of this process for some time, has graciously offered to give up her time. So we thank her for that. And going forward with the network that we create on WhatsApp, we hope that there's a community of caring, that people other than our family are aware of the people in our community. And if there is anybody that needs help, that they can reach out to that person. There are other initiatives which we are still busy with. We're obviously still in exploratory discussions with various groups. Some of those groups, one of them being Benchmark International, which is a well-known healthcare service provider company, research company. They're busy with a research dossier of the North Coast based on national and international trends, which once completed will be given to the board and will direct in the way in which Simbithi moves forward with regards to community-based wellness initiatives. We're also busy with, through our service provider, security service provider, we're busy with rolling out of a panic app, in our Simbithi app, a panic app which is geofenced to the Simbithi location. Obviously, we don't want somebody who's sitting in Italy pushing the panic button and triggering a response. So it'll be geofenced into the area. There are various types of apps that you can use, including buttons around people's nets. We want to create community. We want to support it within our app. So we're busy with that, and that's Nick's forte. That will be coming in the next couple of months. And as I mentioned, in terms of Benchmark International, we're busy doing that as well. What we would like at the end, once Catherine has gone through and run through a presentation, and that we've done some Q&As, we'd also like, if anybody has got some ideas, you're welcome to share them. You're welcome to either chat to myself, Jody, Derek, who's from the board, and you leave us with those initiatives, and we will go out and we'll source whatever we can to try and underpin those. I have, as of yesterday, had a request from one of the groups in the area to come and have a presentation on the various service offerings that they have within their precinct. So that will be coming up in due course, and so look out for that presentation. Then just onto Catherine, if I just introduce Catherine quickly. Catherine's obviously a resident homeowner. She's a mom. She's a registered nurse who's educated in Canada with a master's degree in infectious diseases from the University of Edinburgh. She's been teaching students on wound care, infectious diseases, and general physiology for over 25 years. We're very grateful for you to give your time, Catherine, and look forward to seeing your what I believe might be a scary presentation. So thank you so much.
Okay, well, while they're dealing with technology, technology is always great. My computer didn't connect this morning, and I was just saying to them, I've taken my computer all over the world, and it's always connected. But here in Simbithi, in my local 2 minutes away from my house, it doesn't connect. All right. So thank you very much for being here. As Mark was saying, and thank you very much for the introduction, we have a little bit of a task force to try and get or enlighten our local Simbithians, as I like to call us, a little bit more about health. And one of the things that I've noticed in me being, yes, here in South Africa for over 20 years, is that it's more of a reaction to healthcare than a basically pro-action to health within South Africa generally. Some people ask me, why is that? My personal opinion is that it usually comes down to cost. You know, people don't want to visit, 3 practitioners in a day to find out what the end result is, because it's costly. Okay, so we need to look at that. But also, too, are you actually aware of what needs, what the international recommendations are, what the South African recommendations are for screening, and where can we go from there so that we can be more proactive in terms of our healthcare? So we're going to be looking at, if I can just figure out how to go forward. Okay. Yep. No. Oh, there we go. Okay. So when we're looking at that, I'm kind of defining our optimal health as being a healthy mind and body. I think COVID really brought forth the idea that our mind is a very good predictor as to what our body's going to be. And that has really put us where we are today. We don't want to define everything by COVID, so I'm not going to be talking a lot about COVID today. Actually, I'm hoping not to even bring it up again. But we have to look at, as I said, the reactive versus the proactive. Okay, we're reacting when we have blood through the rectum. We're reacting when a lymph node is enlarged. We're reacting when we have a big, chest that we can't clear. Why are we not looking at the proactive? Okay, and mostly what I'm going to be focusing on today is cancers, but I am going to be bringing in a little bit on vaccinations and those sort of things. Again, what we need to understand is that there's a big proponent of international norms. Okay, so the guidelines that basically we should be looking at in terms of what is international, and is there actually local or South African guidelines that we should be looking at. I also went to a few of our specialists within our community, specialists such as our neurologist specialist, Dr. Dave Lurie, some of our gynae obstetricians, Candice Roberts, and a few others, okay, and also a few of our local GPs to basically get their recommendations as to what locally would they want to be seeing within this community in terms of preventative, okay? So unfortunately, most people don't want to go to a doctor and find out that they actually have problems. Okay, there is a little bit of avoidance, all right? We don't want to actually really know. We might just, like to live kind of erogeously without even actually thinking about it. But we can't. We can't all the time. But that's also what I'm going to start off by saying is that's a personal choice. Okay, where I'm putting out recommendations, I'm putting out guidelines, but at the end of the day, it's personal choice as to whether you want to go forward with a preventative, basically health screening, or do you actually just want to live your life to the fullest? And if something comes about, then that is what it is. Okay. So as I said to you earlier, I think that our previous pandemic has brought forth this mental health, but more so, I think what we have actually been engaging is understanding this stress and health interaction. Stress has played a big part as to getting cancer, okay? Basically, the introduction of diabetes, all right? A lot of different health conditions have an underpinning relationship to stress. And we need to understand that. So as much as we want to connect with others, have time for balance, increase family time, and all those wonderful things, mental stress and anxiety actually play a huge role in decreasing that balance, as we'd like to say, to the final of load shedding. I had to put that in there. There is no ways that we can get away with that, okay? That puts a huge stress. I even saw on CNN this morning, my couple 20 minutes of CNN that I generally try not to watch because it's always doom and gloom. But this morning, we actually were front and center, South Africa, Ramaphosa, and all those wonderful things about us not having electricity throughout the entire country. It sounded like pretty much 24 hours a day on CNN. But beyond that, it does put stress. It puts stress. I mean, thankfully, I hate to say it this way, but Simbithi has not been stressed by that. We have a little bit of, we've avoided it completely. But the general South African outside of this world is stressed by it. Basically, you are moving your life according to the needs of load shedding, the effects that it has on your businesses, getting to and fro places, et cetera, and increased risk of car accidents and all those things with the lights being out and everything. So we really need to take this, because cortisol, being the end stress hormone that we have in our body, affects most of our health conditions over time. What we noticed too is that there was a huge suicide increase, okay, with the pandemic. And we need to be aware of it. We need to look at our family members. We need to look at our community members. And we need to be aware that if the stress, if the mental anguish is there in forefront, is there something that we should be doing? Should we intervening before an adverse event like this occurs? Oops, go back. So the one thing that we do know is that cancers are increasing worldwide, globally, okay? There has been a huge shift in understanding cancers and where they're relating to each country internationally, okay, or globally. I put this one up because this mortality, 5-year mortality screening is an international or global perspective, and it's mainly focusing on diabetes and its relationship to cancer. But what's very interesting, okay, is that every 5 years, this is pretty much updated. And within the 2020 model, okay, we're actually noticing that there was a huge push towards more of a prevention and screening intervention as opposed to a treatment. And that's what was really, really important. So although they're looking at you can probably see here, breast cancer is one of the lowest on the global scale, but it is still the most screened globally. It is still the most highly evocative, if I want to say that, to most countries. We still look at breast cancer as being highlighted month on month, year on year, okay? Whereas things like testicular cancer, you don't hear about it until it's the month of Movember, okay? And then basically the rest of the year, it's not even spoken of, okay? So there's certain cancers that we do need to highlight. There are certain things we need to look at. And then you can see that there are a few adverse events or conditions related to diabetes that are also on this, okay? So the diabetic foot ulcer, nobody speaks about that. And I can tell you, there's a good handful of people within our community that have very difficult to heal foot ulcers related to diabetes. And that is debilitating. Not being able to get to golf, not being able to go for a walk, not being physically active, having to pay for dressing changes, seeing a practitioner 2-3 times a week. So the cost to not only, the physical financial cost, but also the physical mental cost to it. So these are the sort of conditions we need to look at, and also just look at recommendations as to how could we better screen ourselves and be aware as to how we can reduce this risk. So cancer is definitely a leading cause of death worldwide, okay, accounting for about 10 million deaths in 2020 and nearly 1 in 6 deaths globally. Okay. Sorry, this is all the doom and gloom, but we need to get it over with. Most common cancers are breast and lung and colon and rectum and prostate cancers. Okay, what we found globally again, all right, is mostly in the men, it's lung and prostate, colorectal. Women, it's still breast, colorectal, okay, and cervical is up there. Cervical is one of the top leading cancers within South Africa. Okay, so this is global, okay, but within South Africa, it's actually cervical. Anywhere between 1/3 of deaths from cancers are due to tobacco use, BMI, a high BMI, so body mass index, alcohol consumption to extremes, okay, low, high protein intake, all those braais within South Africa. And I've been told, especially by my husband, that vegetables are not on a braai. Yeah, we do have that discussion all the time. Okay, lack of physical activity and stress. And again, the stress and the cortisol levels over years and years of accumulation play a huge part in terms of basically any of our cancers. Most cancer screening has been recommended to begin 5 years earlier. So when I bring in this screening, I'm going to be telling you internationally what has been recommended. For example, colorectal has always been recommended that at the age of 50, you have a colonoscopy and a gastroscopy as your baseline. Well, now it's 45, and I'll explain why. Cancer-causing infections, such as HPV and hepatitis, okay, are responsible for almost 30% of cancer. I don't even think most people know that. So chronic hepatitis infections, unknown HPV infections. So I'm going to go into HPV. I'm not going to go into hepatitis today, but I'm going to go into HPV. For those with younger children, I think this is really important. HPV in South Africa. Okay, so for those that don't know it, it's human papilloma virus. It is a virus that is sexually transmitted. It is the most common STI, sexually transmitted infection, within South Africa. Almost 60, well, some of the studies that I'm looking at are anywhere between 66 and 84% of our population is infected with HPV and not knowing it, actually. So HPV can occur, obviously, when we're sexually active. So it can happen as early as any sexual experience onwards. Okay, doesn't come with a lot of symptoms, but one of our problems is that it lays dormant and all of a sudden it rears its ugly head and we get colon and rectal cancers later on in life. In our practice alone, we've diagnosed in the last 5 years rectal cancers related to HPV approximately, and this is our small practice within Ballito, almost 15 patients. Okay. So this is one of the viruses we need to keep an eye on. It's one that should be tested, and I'm going to go into a little bit more detail later. Okay. Sorry, it's just under that heading there. But basically, that's fine. Okay. So when we're looking at the cancers and what we should be looking at to prevent, that's great. Thank you. Okay. 60% of cancers occur in people over 65. That's a global standard. In this country, it's at 55. Okay, so South Africa is a little bit lower, all right, that we start our initiation of cancers or our checks. We can look at all these things. I'm not sure this is not coming of any surprise to anybody. Tobacco use, that we don't do regular health checks, maintaining our body weight, healthy diet, all those wonderful things will minimize our risk. But we need to screen. Okay. For those that like vaccinations and don't, I'm just bringing it out there. Again, vaccinations are your choice, okay, for the most part. Children's vaccinations are still of choice. People think that they don't have a choice because they send them to schools, but you still do have a choice. You have a human right and a choice. So what is recommended is obviously all the children's vaccinations that are throughout the years, okay. And then the one that will affect more the older generations is maintaining your tetanus. There is still tetanus, basically Clostridium tetani within Africa and within South Africa. It's about 7% still. So there's still a risk with you picking up a rusty nail and basically having a little opening to your skin. Okay, any soil, the tetanus generally is in the soil. So those are the sort of things you need to look at. And if you are cut and you have an opening to your tissue, you do need to get a tetanus update. Okay, a lot of people think, oh, that's just a small little cut, I don't need to see my practitioner. Yes, maybe not for the cut, but for the tetanus you do. Okay, so it is recommended every 10 years. If you've had it within 5, you generally don't need it. But if it's greater than 5, even if you say, oh, yeah, it's like 5 years and 2 months, you need to go and get it. Okay, so that's where your GP or any of our clinics, say at the pharmacy or the chemist, they can also give you a tetanus injection. HPV, as I said, it's not something that our older population wants to worry about, but we need to look at it. Okay, your vaccination for HPV is only as a child, so from the age of 10 to about 26. The reason why the vaccination is cut off at the age of 26 approximately, and there's not any good studies on this, but they're cutting it off at 26 because they're saying that if you were to get a vaccination at 26, you more than likely have already been sexually active. And so it's probably not going to help you at that point. So the idea is that you need to get this vaccination prior to sexual activity. So that is where the males and females, okay, so in this country, just for those that have either grandchildren or children within our population, it starts between the ages of 9 and 10. They can get it through a government school. Okay, they will come in, but South Africa is only giving it to girls. Okay, so it's basically paid for by the government for girls. Okay, in order to have a sexual transaction, you need to have a male. Or, well, maybe I shouldn't say it that way, them, they, whatever. But anyways, there is always another partner involved. And therefore, in most countries, males are also being vaccinated. Okay, so don't exclude the males in this vaccination. Generally, for those that don't know, just going on to HPV, just for if you wanted more information, there are 2 regulated vaccinations within this country, Gardasil and Cervexil, and basically they will take care of basically the type of HPV that would cause cervical cancer. That's what we want to look at, okay? And so they have to attenuate to that. Those vaccinations are usually twice, so 1 and then 6 months later for those within that age group, okay? Seasonal and influenza, that's also a personal decision again. It is internationally recommended that basically anybody greater than 6 months of age up to the age of 75 should have a seasonal flu vaccination, okay? They're right now, the local one is a quadrivent, which is looking at 4 different species. Okay, at this point in time, it changes every single year according to the flu, okay, and what we have out there and what is affecting our communities. And that again is your choice. Okay, so generally we do it in spring, okay, prior to autumn, prior to going into winter. So that's generally when we'll be doing it. Okay. Travel vaccinations, again, I'm not going to go into them in any detail, but there's a whole host of travel vaccinations that you can have, and they're preventative again. So what we're doing is we're trying to prevent the risks, such as malaria if you're going to Mozambique. Okay, that's not a vaccination, but you can look at any of the like the methoquin and all those sort of anti-malarial pills that you can get. Okay. General screening, we're just going to go through the ages. I've basically put an age at 40 because that's sort of when we start to change. So I've put males and females less than 40 and then above 40. So let's talk about general screening under 40. It's pretty much the same for men and women. You know, we need to start watching our hearts, especially with all the stress that we're under and everything else. They'll be inclusive of going in once a year, okay, to your GP, your local GP, having your blood pressure taken, having cholesterol, ECG if possible, looking at your vitamin D levels, which always helps, you know, look at our cortisol and helps with our mental health. Okay, every GP will have a different plethora of bloods that they would like to do and that they see as being important. Okay, so I'm not going to take that away from them. They need to make that decision with you. But it's very helpful, and it's extremely imperative that we understand, or at least get a baseline. Maybe in your mind, it's not yearly, but maybe it's every 2 years. Okay, and especially when you feel change, and I cannot express that enough. When you feel change in your body of any sort, your bowel movements are not the same. Your urination is not the same. You're feeling aches and pains when you get up and you didn't have them before. Anything that's a change in your body, okay, is really something that if it doesn't go away within a month or two, you really need to have that looked at. And that's the GP is a port of call. Okay, they're the ones that will look at that and then refer you to a specialist if need be. We can look at weight gain, both in men and women. Weight gain can be indicative of a thyroid change in a woman, not so much in the man, but it can be. All right, so getting a baseline TSH at about the age of 30 for women is really important. Okay, past that, they suggest that you do it every 5 years or so. Okay. For diabetes, I'm going to talk individually on diabetes, but basically they brought the diabetic screening from 35 to lower than that, okay, till about 30, due to the global obesity that we see, okay, throughout the world. So we need to really be aware. I saw that. For those that are listening to this, it was just a monkey that went for the muffins. So they've moved anything less than 35. They're suggesting 30, especially if you're obese, you have a family history, etc., to get a baseline blood sugar, basically a fasting blood sugar level, and a hemoglobin A1C. For those that aren't familiar with a hemoglobin A1C, it is looking at your level of sugar within your body over a 3-month period of time. So it's an average, okay, and it comes in a percentage. And that's a longevity. So we can see, you know, that one day that you had your fasting blood glucose and you starved yourself the night before and you come in and you get your bloods taken, that is only really looking at, you know, that fine window of 24 hours. But the hemoglobin A1C looks over basically 90 days, 3 months. And so that gives you a very good understanding over a period of time where you stand in terms of diabetes and if you're pre-diabetic. So that's really quite important. Cancer screening in the less than 40 and the women and the men. Okay, mammos, so mammograms and ultrasounds, extremely important. Okay, what we had noticed in our small practice, especially since COVID, is the amount of breast cancers that we have seen and diagnosed and latent, basically, stage. So we're talking stage 3 and stage 4. I don't know what that was about. I don't know whether people just got so busy with COVID and it just took over their mind, their mental state, etc. But we need to maintain our mammograms up until the age of 75. And some countries recommend to the point of 80. Okay. We still get latent cancers, breast cancers, okay, within all countries. All right. Generally, the ones that are young are the ones that have a genetic predisposition. The older ones are environmental. Some people say it's too much caffeine. Some people say it's exposure to the weird and wonderful chemicals in the world. We don't really know, but you can still get cancer in a latent stage. Okay, so less than 35, family history, and on a yearly basis. Cervical cancer, generally related, as I said, it can be related in this country to HPV. It's a strong correlationship to HPV. A pap smear is looking at the changes in your cells. So for all the women in the audience, you know what we've been, you know, what tests we've been having forever. Okay, an internal with a pap smear. Now, what's different is that you can actually have HPV screening also. Okay, so you can also ask them to HPV screen, which is a different cytology that you can have done. And so it will not come as your normal screening. It would have to be separate. So you'd have to include that in, and you can ask your gynecologist to do that, or your GP, whoever you get your internals with. Okay. Testicular cancer for men. Okay, it is basically about teaching your young men, okay, and your husbands and everything else to do a self-examination. Okay, they must test their testes. They must know how they feel from a very early age. And when there is any change, that is when they need to bring that forward. So there is no blood test you can do, no other screening. It is a self-diagnosis. Similarly to women, okay, doing our own breast examination. I'm bringing in diabetes because I think it's extremely important that people don't recognize some of these subtle changes that we might have in a pre-diabetic state. Okay, people think it's the common, the thirst and feeling, you know, lightheaded and all those wonderful things. So that could be many diagnoses. You know, our differential on that is extreme. But what we need to understand, especially with weight gain, okay, we need to look at that as sort of a precursor to what we need to test. So just for those that don't know in the audience, basically type 1 is autoimmune. Okay, they used to call it juvenile diabetes, and that generally happened within our teenage years. Okay, we've kind of changed it throughout the years, and we have type 1 and type 2 now. Type 1 being that juvenile, still within generally our teenage years. Okay, autoimmune, something just triggers the body into not basically making insulin anymore, and we basically go into a diabetic state. Okay, it's fairly acute, meaning that it is very reactive. It's basically one day to the next, pretty much. That's generally the way it presents. Whereas our type 2, which has always been kind of presented to me as being gluttony, it is our weight gain. It is us taking on too much sugars. Our cortisol levels actually interfere with our absorption of our sugar and our good maintenance and not being able to get insulin production up to its optimal amount. Okay, so this can happen. You can be pre-diabetic, you can be diabetic, and you can go in and out of it as the years go on. Okay, once diagnosed with type 2 diabetes, it doesn't mean that you have to sit there with type 2 diabetes. You can make changes to your health, to what you eat, to your physical activity, and change that from a diabetic state into a pre-diabetic and possibly not even diabetic anymore. And I think that's what's really important. But where globally they want everyone to look at is we start testing our fasting blood glucose at the age of 35. Okay, we can also do a urine test. All right, this is part of your normal health check. And then as we change, our BMI goes up or we go down, we have extreme weight loss. Either way could actually be indicative of a diabetic change. Every 3 years, okay, according to our activity and our weight levels and our changes, that's what we should be looking at on average. Okay, if anything between those 3 years come up in terms of changes, frequency of urination, feeling lethargy at the end of the day, any of those general norms that we think might be normal, well, let it occur for a month or two. And if it's not going away, then you need to see the GP, okay? Because then it's a sustained state and your body is dealing with something, okay? Our general screening above 40 now, so according to basically the international norm of women and men, routine bloods again, okay, looking at that, making sure we're looking at our heart, okay, our heart health, our basically bladder health, all of our health. Okay, so just getting a good overall screening, both men and women. Okay, they will also, the GPs, for example, will also look at your BMI. They'll do a BMI screening. And then, especially in this country, looking at the skin lesions. Okay, that's when we should start. But at the age of 40, we should start looking at skin lesions. You've had a good 20, if not 40 years of sitting in the sun. And we need to really make sure that we look at all those skin lesions, okay, and notice them. Most people just want to go to their GP, which is perfectly fine. We also have local dermatologists, and then we have the local surgeons and the plastic surgeons that can deal with extraction, okay, or basically removal. Cancer screening above 40. This is where it gets a little bit sticky. As I said, we brought all cancer screening globally down 5 years. And if you read the research, there's a lot of information to tell you why this is occurring, but there's not a lot of good randomized control studies to actually give you good reason. The bottom line is that they feel that our obesity is going up globally, that we're not eating well, there's much more preservatives in our food. Okay, the environmental that we're exposed to and the chemicals that we're exposed to is rife. So for all of those reasons, they brought the cancer screening down about 5 years. And in colorectal specifically, so Canada and the UK put out a good global recommendation about 5 years ago, saying that they're lowering that international screening from 50 down to 45. And their rationale was that at 50, they're actually finding neoplasms. So that's precancerous lesions or cancerous lesions, okay, at usually stage 1, at the age of anywhere between 45 and 50. So with that in mind, and the amount of these neoplasms that they were finding within that age group, they said, why are we still screening at 50 when we're actually seeing cancerous lesions greater than 45? So that's why they brought it down to 45. Okay. So colorectal is extremely important, especially in the males. It's higher incidence in males than it is in females, but that doesn't say, you female in the room, that you can ignore this. I know we all want to, but we cannot. Okay, colonoscopies and gastroscopies are not as bad as everybody thinks they are. Okay, you are out. You are under conscious sedation generally. You are not under general anesthetic, and it really is a very quick procedure. So the global recommendation is at 45, get a baseline. Okay, that'll also show whether you're a polyp former or not. Polyps are gross, okay, and that would be related to precancerous lesions within your rectum and within your colon. So that's something to really look forward to. We are looking at a recommendation of every 3 to 5 years after that. If you're a polyp former, then most of the surgeons within our area would suggest every 2 years approximately that you go in and you have another screening done. Okay. The interesting thing is that people actually don't. So if you have not had a previous colonoscopy, gastroscopy, people are still wondering, like, should I have one? Yes, of course you should. But alternative to that, when do I go in? Do I just make my appointment at 5 years and just leave it at that? No. If you have any changes to your bowel habits, that's extremely important for you to recognize that that is a change, and not just from in 1 week. So there are times where we have a virus come through, or a bacterial, like a gastritis, okay, a little bit of inflammation. That might be a week episode. But when diarrhea or the opposite, constipation, goes on for months on end, that is when you need to understand that there's been a change to your bowel habits. It's changed from what your normal was, and you need to get in to see someone regarding that. Okay. The first protocol, some people will also do a fecal occult blood. So for those that aren't familiar with that, that is when we take a stool sample and we check for minute, basically blood cells, okay, in there. If there is, which you will not see, if there is, then we say that's fecal occult blood positive, and that means that your stool is rubbing up against a growth and possibly causing bleeding that you would not see, internal bleeding within your colon, and therefore then we would need to check out what this is. Okay, so just to give you a little bit of a background, so for those that have not had this screening, there's always tomorrow to start. Okay, from a men, so men also have to have the colorectal screening, but they also have to have the prostate screening. Okay, so from the local urologists, they recommend that basically you start your PSA, okay, which is a blood test, and a examination, okay, almost on a yearly basis past the age of 45. And in some countries, again, as I said, the global recommendation is at 45, but in some countries, they're starting as early as 40. Okay. So the other topic that I was asked to talk about was, so our next screening is basically we're looking at our mental health. Okay. And we're noticing, well, we were saying the statistics within Simbithi is possibly anywhere between about 1,500 to about maybe 2,000 older population within Simbithi that maybe need to look at, number one, health screening, but also looking at mental state, okay, as we get older. As much as we would like to say that we're going to keep our faculties till we die, we don't necessarily. And so is there ways of us doing a pre-screening for dementia and Alzheimer's? Okay, changes to our mental state. And there is. So globally, we look at this mini mental state examination. Any of the GPs can do that, okay? And also too, I have spoken to our local neurologist. He will also do those examinations, but it's a quick examination, takes no more than 10 minutes, all right, where it's a set standard questions, okay? There's 11 items, and this is a worldwide activity, okay? And it's encouraged in most countries. Once that is done and you're deemed that your mental state is good at this point in time, but most people say that, you know, you don't need to go back again. No, when you're changing, and that could be a change to your memory is lost. You don't remember what was happening this morning. Okay, you don't remember to turn off the stove. All right, you've lost your keys. I've lost my keys, and I'm 53, but I'm not sure if I need to go to a mini mental state examination. But if this is continuous, okay, then this is what we need to look at. So if you notice that your partner, your grandmother, your parents, your children, this is not exclusive to the older population. This could be for anyone, okay? This mini mental state examination can start as early as 45, all right? So in some countries, when you notice that their faculties, and generally that 45-year-old, there will be an underlying cause, okay? Just not basically that you're older and your brain is being affected and everything else. This could be due to, you know, basically a neoplasm of the brain. Could be many different causes. It could be also cardiac. There are so many diagnoses that we can't even go through, but early detection at 45 is recommended. The general norm would be greater than 65, okay? And in some countries, the general norm is actually 60, because in some countries we have retirement. I think it's what is it, Italy or something recently, that they want to bring retirement from 60 to 62, and there's a big outrage. Was it Italy? I don't know. It's recent that they wanted to bring it up. Was it France? Thank you. It was actually France. And so there's this complete outrage. How could you bring that level up higher? But generally, most countries are looking at the age of 60. Okay, but the international recommendations, according to the World Health Organization, is 65. So I think that basically age will be dependent on the working population, how old the population is within the country that you're living. France seeming very young because now they want to bring it up to 62. So I think it depends on which country you're looking at. But we also, when we're looking at early detection, we also have to rule out a whole bunch of other underlying medical disorders or conditions that would mimic dementia, okay, such as depression, drug interactions. There's some people, I mean, I've had people come into the practice with a whole truckload of medications, and they don't know half the time what they're used for, how long they should be on for, because this practitioner has ordered it, and then this practitioner has ordered it, and it's a whole slew. And that also is really important. And again, that's where your GP comes in, okay, where they take all those medications and they alter them and they make sure that you're on the right medication, because a drug interaction, okay, can also mimic our changes to our mental state, okay? Delirium, hearing impairment, just not even being able to hear can alter your mental state. And some people don't even realize that they're losing their hearing. So ruling out all of those conditions prior to actually saying that you're demented or that you have Alzheimer's is a pre-testing that we should be doing. Okay. 10 signs for early detection. If anybody wants to take a picture of this, it will be on the Zoom call also. Okay. I think any of these, but this is just not a once-off, as I said earlier. It's not that this just happened one day. It's that it's progressively, that it's every day, or it's progressively increasing in terms of days and over a period of time. You know, we're talking months on end. Okay. I'll just wait a couple of minutes for those that want to read through it. And again, I can't. Most of these guidelines are looking at 75 because that is basically, you know, when we look at the lifespan within the global lifespan, okay, most countries have a mortality or morbidity at around 75 and lower. So males and females obviously differing per country, okay? And that's why most of the guidelines sit at 75. But, you know, when we look at some of the countries, people are living till 80, 85, 90, and still in good health. So as I keep saying, it's a recommendation. It certainly does not have to stop at 75. I mean, if you're a woman and, you know, very healthy and up and active and everything else, and you don't think you have to have a mammogram after 75, no ways. If you're active and playing golf at 85, then your mammograms continue, okay, every 2 to 3 years. Okay, so as I said, it's just a global recommendation. So no, you're still young, very. The 75 is now the 65, isn't it? Okay, so kind of in closing, we're sort of looking at screening as your choice. I'm certainly here just to enlighten and to hopefully just bring some new thoughts into the screening process throughout the ages, making you aware, you know, if you're older, but you've got grandchildren or you've got children and you want them to be aware, you need to be aware for them. I think it's just really important of understanding what do we need to screen, how can we screen, and who do we need to go to get this screening done? And I think that's important. But again, it is your choice. Okay, take control, ask your questions. Okay, have these discussions. Don't necessarily go in guns a-blazing tomorrow saying I need to start from head to toe, but understand what is out there and what needs to be tested. Okay, and be fully aware of what your body changes are. You know, you should understand your body. And if there is changes to your habits, bowel habits, urinary habits, breast, you know, thyroid, looking for things, even swallowing, okay, all those things that were not normal to you before, then that needs to be looked at, okay? Take control of your own health. So really, you know, looking at everything that's out there, there's not a pill for everything. Everybody wants, especially in the practice that we've been in for a while, everybody wants a quick fix. There's not a quick fix with any of this health screening. And really what we need to do is remember that health screening's there because we live throughout our ages and we're somewhat abusive to our bodies for years and years and years. And we expect this body to keep going at its optimal. And it doesn't necessarily do that. So when you see changes, we need to jump on that bandwagon, you know, in whatever form or fashion that is for you. So have the knowledge, use the knowledge, decide when to use it, and then just take control of your own health. So I want to thank you for today and thank you for coming. And I'm definitely open for any questions. Any questions? Was that an okay summary?
Look after them, that we can heal ourselves in that way.
Yeah, but you need to be aware as to how you can help yourself. So, you know, it is very forgiving, but not over time. So if you continue to abuse your body, I'll use that word as a very general norm. Your abuse and my abuse is very different because every body is going to be different. Every body is going to react to things differently. You know, maybe one person can have, you know, 10 chocolate bars a day and never get diabetes. I'm just using that as an very simple example, but never be diabetic. And then there's others that never have sugar, but still gain weight and become diabetic. So everybody needs to understand that although, and I've been very general with these recommendations, these are global and local recommendations. Okay, it does not mean that, you know, that will partake to you, but it is something that you need to be aware of. And I think my closing or my message is any change to your body requires for a period of time, not episodic. So for a period of time needs to be attended to if you want to be aware.
Thank you, Catherine. There's teas and coffee. We're going to remove the sugar and some muffins outside. Please join us and have some teas and coffees outside. Thank you very much. Thanks, Catherine.